about everything Nclex. So I have done my Nclex some time ago, and I told myself, I promised myself that by the time I pass on my first attempt, I'm going to come back to help others. And I have been receiving lots of questions about resources I used and all that. And I think it is best for me to pay it forward. Now, my background, I am a nurse, so I did my nursing in Nigeria, and then I moved to Finland, currently working in Finland. So, as a foreign educated nurse, I was able to study for the NCLEX and I passed on my first attempt, actually, the 85th question, the NCLEX new gen, I passed. So, I told myself that after my master's, when I don't have so many things going on, I will pay it forward. So, market lecture, this note is one that I used, and I thought that it's best that I come on here to share the note with you. Perhaps you're thinking of, or you just graduated from nursing school and you're thinking of the resources you can use. What are the things that can help you? I hope you find this video helpful. And yeah, but instead of going through this Word document, I'd like to give you the values, lab values you need to know if you're doing NCLEX. These are very important. So the first one is the creatinine. Now, creatinine is the lab value you need to know when you want to check the functionality of your client's kidney. So the value is zero point 0.6 to 1.3. And then we have the INR, that's when clients are on blood clotting medication. So we have the value which is 2 to 3. And then potassium, really for the heart, and the value is 3.5 to 5.5. By the way, I have my notebook now. This is the actual notebook I used when I was preparing for my NCLEX. So I'm going to be reading from here. So in case I'm looking down, it's because I'm really showing you exactly what I used to pass the NCLEX on my first attempt. Yes, so the pH, we're going to be talking about the ABG soon, but yes, the pH first is 7.35 to 7.45. And then the BUN, it shows how dehydrated the kidney is. So the BUN, or well, I won't call it dehydrated. If the BUN is over 20, then you know something is wrong. So it just goes to explain the kidney perfusion, which is 6 to 20. So hemoglobin, which is the protein in red blood cell, the oxygen carrying protein in the red blood cell is 12 to 18. And then we have the hematocrits, 36 to 54. We have the oxygen saturation, the PaO2 of 78 to 100. And we know that oxygen saturation is anything 95 to 100. And then we have the BNP, which actually indicates chronic heart failure. If someone has pitting edema, or there is overweight or swelling in any part, it goes to show if somebody is, or it goes to state the heart condition and perfusion. So the BNP, when it's over 100, it indicates chronic heart failure. And then we have sodium, which is 135 to 1.5, 135 to 145. Also, we have the white blood cell, which is 4,000 to 11,000. ANC should be over 500. Now, CD4, it goes to talk about the HIV and AIDS. So, over 200 is better. So, the more, when it's over 200, we have over 500 and over 600, it means it's better. But if it is less than 500, it indicates HIV. And of course, when the CD4 is over 200, it indicates AIDS. So let's talk about magnesium. Magnesium is about the heart, mellows the heart. That's one thing I used in remembering it. and the value is 1.5 to 2.5. I did mention sodium. Sodium level is very important electrolyte. If you're not knowing any, or if you're not remembering any lab value, sodium, potassium, magnesium, they're very important. Phosphorus, very important. So the phosphorus, the value is 3.0 to 4.5. Okay, that being said, I would go over to the Mackay notes I used. So this is it. We're going to be talking about the acid-base balance. We're going to be talking about ventilators. We're going to be talking about alcohol, Wernicke, the overdose, withdrawal, signs and symptoms, aminoglycosides, the peak and the trough. Very, very important when we talk about the antibiotics like the vancomycin, the big guns. It is very important to remember the peak and the trough, and of course, when to look out for them. Then for the lecture 3, we have the drug toxicities, that's the lithium, the lanoxin, which is also known as the digoxin, the dilatin, bilirubin, and all that. So these are the things that we will go through. This just like the outline of this Marquet book I used to read. So if you're a Christian, this is the point you need to pause and pray for God to help you assimilate these. Now, if you're asking me how often do you need to read this? For me, I read this whole page. So from page 3 up onto page 92, I read that 4 good times. I'm going to link a video to my experience, what I did in preparation for my NCLEX. And one of the books that I use, one of the resources I use is this Marquet book. I read it 4 times. So I have the yellow book, which is this. By the time you're done, I'm also going to link that for free if you want to get it. So the yellow book is like an answer, is like a quiz to these lecture notes. So let's get started. Now, the lecture 1 is the acid-base balance. And it says, in order to solve acid-base disorders, it is important to know the normal values. So the pH, the carbon dioxide, and the bicarbonates, which are shown here. So the pH should be 7.35 to 7.45. So below 7.35, we're talking about acidity, and above 7.45, we're talking about alkalosis. Then the CO2 should be 35 to 45. Now, one link, one hint, one memory trick is if you remove the 7, in this pH, then you just bring down the 3.5 and the 4.5 down. That's a very good memory trick to remember the CO2. And then, which is the carbon dioxide. And then the bicarbonate, we have 22 to 26. This question actually came in my actual NCLEX exam. So it is very important that you know the acid base, the ABGs, you need to know them. So the first value to look out in an acid-base disorder is the pH. So if the pH is less than 7.35, as I mentioned, then it's acidotic. Yes. So, and if it is over 7.45, then we're talking about alkalosis. Then we can say that a client is alkalotic. Now, to determine if the imbalance is metabolic or respiratory, you get to know where this is originating from. Everything relating to the lungs is respiratory, and anything not relating to the lungs is metabolic. This is very simple to assimilate, to remember, to understand. Everything relating to the lungs, respiratory. So it could be respiratory acidosis, respiratory alkalosis. But then if it is nothing relating to the lungs, if it is the brain, the kidney, wherever organ, then we talk about metabolic. So yes, rule of the bees, if the pH and the bicarb move in both direction, then the acid-base balance, though the acid-base imbalance, is metabolic. Other than that, it is respiratory. So for instance, an example given here, 7.35, we know that the normal value is 7.35 to 7.55, as we have mentioned. But here we have 7.3, which is acidotic, and then we have the bicarbonate, which is 20. So this is an example of metabolic acidosis. Example 2 here says 7.58. 5.8 here is alcoholic, that's alcoholysis. And then we have the bicarbonate, which is metabolic. So we have metabolic alcoholysis. And very good, there is a third example, but a very good memory trick is as the pH goes, so does your client or your patient go, except for potassium. This means that if the pH is low, meaning that everything is low, all other values will be low, the breathing will be low, and all that, except your potassium. So in this case, we will say that your potassium will be hyperkalemia. So anything, remember the value, we have 3.5 to 4.5. So if pH is low, your patient is hyperkalemic, and that is over 7.45. So if your pH is high, it means that everything will be high except your potassium. Very important that your potassium is not high or low. It stands on its own, like it has a mind of its own. pH can be high as it wants to get, pH can be low as it wants to get, but your potassium is not affected. Okay. So if pH goes over 7.55, this is alkalosis. Therefore, everything goes up. Now, in alkalosis, one thing I used to remember is it's on the high side because, of course, we have the figure of 7.35 to 7.45. So everything here on my right goes high. It means that the breathing will be high, where we have tachycardia, tachypnea, that's high breathing. Tachycardia is actually high pulse rate. Then the tachypnea is high respiratory rates. There will be hypertension, everything high, everything hyper on the high side. So seizures, irritability, diarrhea, borborygmi, that's increased bowels, and the very obvious one, when someone is really hungry, those sounds you hear that really comes out. And then the muscle strength, the muscle tone will be everything over 3. So +3 and +4, hyperreflexia. So, however, potassium is opposite. Therefore, in the alkalosis, we have hypokalemia. So, what is the nursing intervention? Patients need suctioning. Why does the patient need suctioning? Everything is high, and there will be a need for blood, right? No, there is a need for you to remove the excess coming out. During seizures, they have mucus coming out, saliva coming out. So there is a need for suction. Remember this. Okay, then we talk about everything is low, like I'm tired, I am weak, I cannot go on with life, is the acidosis. Okay, so when we talk about the acidosis, it is 7.35 to 7.45. So what do you think in acidosis? It means that is anything below 7.35. So 7.35 downwards. And it means that, like I said, there is tiredness. So there is bradycardia, constipation, absence, bowels, and hyporeflexia in the muscle. There is bradypnea. So the breathing will be low. The pounding pulse that we saw in alkalosis will now be low. So there will be really low. Everything is low. But in the acidosis, in whatever it is, metabolic acidosis or respiratory acidosis, the potassium is high. So there will be hyperkalemia. In the hyperkalemia, that is any lab value of potassium that is over 7.45. So remember Mark Kuzma, and this is the only acid base imbalance to cause metabolic acidosis. So this is pretty easy. Metabolic acidosis, remember Mark. I think when you want to remember as a memory trick is metabolic M, acidosis AC, and it is the only one with metabolic acidosis. So, what are the causes of metabolic acidosis? Now, these are some of the things that you may likely see in your NCLEX question, in your actual NCLEX examination. First, you ask yourself when you want to define or determine if it is acid or alkalosis. So, you ask yourself, is it affecting the lung? If it is affecting the lung, then it is respiratory. Then you ask yourself, over ventilating, we have already defined that over ventilating is anything alkalotic because it's over, everything is high, is hyper. Then under ventilating should now be acidosis, right? So if it is under ventilating, then you're going to take acidosis. But if it is over, and if your client is like gasping for breath and not really breathing in, then that's like alkalosis. Okay, so what type of acid base derangement is present in the following condition? In labor, what happens in labor? Well, I was in the delivery, so I know that women tend to pant and breathe kind of shallow but fast. So that will be everything breathing, lungs. It means over ventilating because the person is breathing too much. That defines is alkalotic. And then we're talking about breathing, it means that is respiratory alkalosis. Then when someone is drowning, you're immersed underwater, you cannot really breathe in well, then the person is under ventilated, and we're talking about the nose in this sense. So that's like respiratory acidosis. Okay. And then when patient is on a patient controlled anesthesia pump, it means that ventilation goes down, because one thing you should know about these medications, the methadone, oxycodone, these strong opioids, one side effect of opioid is that it affects the respiratory organ. So there is a high tendency to, well, the side effect is under ventilation, and that is why you need to check your client all the time. So because we're talking about under ventilation, risk for respiratory depression, you're going to think of respiratory acidosis. Okay. So if it is not the lung, then it is metabolic. So if the patient is vomiting, having diarrhea and all that, it means is alkalosis. So Marquet says for everything else that isn't long peak metabolic acidosis, like life is that simple. It is simple. If you know these two rules, is it anything relating to the lung? No. Okay, I'm picking metabolic acidosis. Okay, I'm picking metabolic, not yet acidosis, but metabolic. But then when you come to the if it is acidosis or alkalosis, then you ask yourself, is this over or under, hyper functioning or under functioning? And then you know. So the tip is set your default setting to be everything is metabolic acidosis, and always pay attention to the modifying phrase rather than the original noun. Okay. So this leads us to the second lecture note, which is ventilator. Now, ventilator, if you use the Uworld practice questions, you will get a lot of questions relating to this. I think I also saw one question in my actual NCLEX exam on ventilation. So, a ventilator is a machine designed to move breathable air into and out of the lungs. It helps patients who are physically unable to breathe or breathing insufficiently, or yeah, to breathe. So a ventilator is equipped with a high pressure or low pressure alarms. Now, this is where we want to talk about. We don't really want to talk about how the ventilator is made, what it is made of, but the most important thing that we as nurses, our nursing responsibility, things to look out for is what we're concerned about. So high pressure alarms shows that there is pressure, increased resistance in airflow. When you think of high, I think this is the memory trick. Anything high pressure, it means there is high resistance, high volume, increase. So it's like it goes hand in hand. And what are those things that can indicate that your client has high pressure? Or when the alarm rings and you're somewhere, perhaps in the nurse's station, what are some of the things you can think of? You look for obstructions. So the obstruction could be kinking in the tubing. Maybe there is condensed water in the tube. That's simple. If there's condensed water, you just empty it. If there is kinking in the tube, just unkink it. And if there is a mucus plug, then you ask the patient to turn, cough, deep breathe, or of course you suction as you suction the tubing when needed. But then, what is the appropriate order to address a high pressure alarm in a mechanical ventilator? The first thing is unkink it, empty the water, turn the patient or ask the patient to breathe, to deep breathe and all that before suctioning. Suctioning is always the last because you want to encourage the patient to breathe on his or her own. So first of all, you do from the less invasive, less tasking to more tasking. Unkinking is very easy. And then when we talk about the low pressure alarms, we're talking about low, there is decrease. Memory trick. When it's low, then there is a decrease in resistance. And this could be perhaps the tubing got disconnected when the patient tried to pick up the phone or tried to turn, or the sensor, the oxygen sensor was disconnected. Well, in both cases, reconnect them and your patient will be fine again, and that pressure, the low pressure alarm will turn off. So the ventilator may be set too high or too low. If the setting is too high, it means that patient is overventilated. And in this case, remember our ABG overventilation, remembering that it's relating to the lungs. So here we may have respiratory what? Alkalosis. So yeah, panting. I actually didn't see that. But if the setting is too low, it means that there is a disconnection, low pressure, low resistance, and the patient will be on the ventilating. There is respiratory acidosis. And remember, in respiratory acidosis, one way to combat it is giving more oxygen because the patient is not getting enough oxygen and retaining more of the CO2, carbon dioxide. So, a question here: the physician wants to wean off a patient in the morning. So, at 6 a.m., the ABG says that there is respiratory acidosis. What do you do next? Now, remember, what this question is asking you is: physician is saying the patient has had enough of oxygen, okay? But then you check your ABG value and it says that there is respiratory acidosis. Respiratory, relating to the lungs, acidosis on the ventilating. Are you going to fulfill that order? No. You're going to tell the client that, hey, you're going to tell the HCP, healthcare provider, that these patients you're saying wean off. The ABG value says that there is respiratory acidosis, meaning there is not enough. You actually need to prescribe more. So, yes, therefore, the patient is not ready to be weaned off. But if this client was in respiratory alkalosis, then it is a very good intervention to fulfill the order of weaning the patient off. So this brings us to the second question lecture on Mark, which is alcoholism. It says that it's a psychological problem, and well, the number one psychological problem with alcoholism is denial. So, how do you respond to a patient who has denial? First of all, you confront them by pointing out the difference between what they say and what they do, because some of them can say, I don't actually drink, it is my wife or my spouse that does the drinking. That is denial. And as a nurse, it is your responsibility to point it out straight that you said you don't drink, but here at your bedside or somewhere, your spouse have said that you do. So, for instance, say something like, okay, you said you're not an alcoholic, but it is 10 a.m. and you've already had 6 pack. So, it is not the same as you being an aggressive nurse. It is just for you to state the obvious, state so that they get to realize that they are still in denial. So the good answer is I, bad answer is you. One place where denial is okay is loss and grief. When someone is saying or grieving the death of a loved one and all that, it is okay. So now we talk about the stages of grief that you may likely see in your NCLEX exam, which is the DAB. DA. The D standing for denial, A standing for anger, B standing for bargaining, D for depression and acceptance. In denial is like my wife or someone that had not died. Like he said or he or she said he's going to come back. He was just going to the grocery shop and then something happened. And then the second stage is anger. If I knew, I would have gone with the person, or if I knew, I would have stopped the argument and all that. It is because of me that the person died, for instance. And then the third stage is when they say, okay, if I go out, this person is going to come back with me. Like the person is going to come back from the shop and all that. Then depression is when it dawned on them that, okay, really, this person is gone, and there's this overwhelming sense of misery that comes upon them. And the fourth, which is the fifth, which is the final stage, is finally come to accept that yes, this has actually happened in terms of grief. Okay, so when the question is about patients in denial, pay attention to whether you're dealing with loss or abusive situation. So if it is a loss, it is not the time to start saying that you need to confront and all that. The client needs support. But if it is an abusive situation like alcoholism and all that, it is time to confront and tell them, you say this, but your action says the opposite. Okay, then we go forward to. There is a question here. So the title of the section is Alcoholism. However, this rule can be used for any abuse situation. So, what is number one psychological problem in child abuse, in gambling, in cocaine abuse, in spousal abuse, in elder abuse? The number one problem is denial. The answer is always denial. Okay, so going to dependency and codependency, the psychological problem, the number two psychological problem is dependency or codependency. So dependency is when you get a significant order to do things or make decisions. For instance, the abuser is a dependent, okay? And then codependency is when the significant other. Now, let me bring this to light. To light. Dependent, like when you say dependency, is if I am an alcoholic and then I make my spouse or I make my kids to go buy drinks for me, to do the things that I want to do because on my own I am known as one that buys the drink and perhaps there is a ban. So making others do the things for me, then I become that dependent on them. But codependency is when they now accept, like they encourage me, they do those things for me, they support my decision, then it means that that's my significant other, my family members, they are now codependent. So dependency and codependency, it's like a symbiotic relationship, yet a pathological relationship. So, how do you treat dependency and codependency? For the dependents, which are the patients or abusers, first of all, you confront them. Or codependents, patient, they have some kind of self-esteem issues. So teach them how to set limits, boundaries, how to enforce those boundaries, how to enforce those limits, and then agree in advance on what requests are allowed and then enforce them. So you can just tell them straight that they cannot, for obvious health reasons they cannot give in to the request of the dependent of their spouses, asking them to buy drugs or asking them to buy drinks. So if you're able to give them those phrases that for this reason or that reason, for your health issue, looking at the nobler cause, then they'll be able to accept the boundary, the limit, and be able to enforce them. So the other thing on codependent is to work on their self-esteem. That brings us to manipulation. Manipulation is when the abuser gets the significant order to do things or to make decisions that are not in the best interest of the significant order. And one way this is exposed is when they say you need to buy or you cannot leave the house, when a client, one with low self-esteem, doesn't want the husband to leave your house, and it's like, you're very wicked for leaving the house. So they manipulate them to do things even if they know that they are just dealing or toiling with their mental health. So the nature of the act is dangerous and usually harmful to the significant other. So how is manipulation like dependency? In both situations, the dependent person gets the codependent to make things or make decisions. If what the significant order is being asked to do is not inherently dangerous and harmful, then it is dependency or codependency. So in codependency and dependency, there's actually, it is not dangerous. Yes, it is not nice, but then it's not dangerous, it's not harmful. But in manipulation, there is inherent dangerous or harmful cause that come with it or harmful consequence or repercussion. So it is important that in manipulation there is limit and ew, there is limit and those limits need to be enforced. Okay, so I hope you guys are liking the video and getting something from it. This will really be helpful to me if you're able to support by clicking on the like button and leaving your comment so that this can actually reach other people. And yes, so please click on that like button so that others can find this video. I think this is me fulfilling my path of reading this to you and just going through this lecture with you. Okay, so examples here for us. Determine if either of these situations is dependent or codependent problem or a manipulation. Remember, codependent, dependent is not harmful. Manipulation is harmful. A 49-year-old alcoholic gets his 17-year-old son to go to the store and buy alcohol for her. So, is the first one. The mother is manipulating the son. This is an illegal act, which is harmful. But dependency, there are two patients. The dependent has a denial issue, and then the codependent has a self esteem issue. A 49-year-old asks her 50-year-old husband to go to the store and buy alcohol for her. Now, in 17, remember, this is manipulation because the child is underage. It is illegal. It is harmful. You're exposing that young child, young brain to alcohol. But then 70, a 49, asking the husband, they are the same age, the husband already understands the consequence and does not really have a ban. Then we don't call that manipulation, we call that dependency. Now, this is not illegal, there is no harmful thing because the adult in this case can decide that I don't want to do it or I want to do it. Or then there is a need to work on the person's self-esteem, but then it is not harmful. It is not dangerous. There is no inherent danger. So that is why this is called dependency situation. So we have the Korsakoff syndrome, which is the Wernicke syndrome. Typically, the Wernicke and Korsakoff are two separate disorders, but the Nclex, however, bundles these two in one condition. So Wernicke is an encephalopathy and Korsakoff is psychosis. So Wernicke and Korsakoff tend to go together. In Wernicke and Korsakoff, one thing you should remember when you remember the WK, that's my memory trick, is psychosis induced thiamine, that's vitamin B1 deficiency. I gave a client in my workplace, an alcoholic actually, Neuramine. It is called, the trade name in here in Finland is Neuramine, which is the vitamin B1, because he was really deficient of it. And as an alcoholic, it is missing. Alcohol actually reduces the amount or availability in the blood. So this is a situation that patient loses touch with reality due to vitamin B1 deficiency. Now, the primary signs and symptoms is one, memory loss. They will not remember so much. And there is this confabulation. They don't remember, and instead of them to shush, they start making up words to kind of make up stories for the memory loss. So confabulation is the lies for these clients. The lies for these patients are just as real as reality. So they truly believe that whatever they were saying, the statement they were making, was true. So how do you deal with this Wernicke and Korsakoff, who is confabulating about going to meet Barack Obama this morning? The best thing to do is to redirect the patient to do something he can do. For instance, you tell the patient that, why not we go watch TV or to see what we have on the news? This is a very wise way and non-dangerous way to redirect the focus, because in this case they truly believe that they have a meeting with Barack Obama and they were going to meet Barack Obama that morning. Okay, so characteristics of Wernicke and Korsakoff syndrome. Number one, it is preventable. So in NCLEX, they may ask some of the things like, the new gen question where we have the bow tie. In the middle can be the question, which is the Korsakoff or Wernicke. And then here is signs and symptoms, where we have the memory loss, confabulation. And then on the right side, it could be preventing, which is taking vitamin B. So you can just click to add vitamin B. So we can also, if they've already developed the symptom, it can also be taken care of, maintained, prevented from getting worse, that's arrestable by giving them vitamin B1. But then the irreversible one is 70%, which is when there is a death in the brain cells. Now we have antidotes and Revia. So antidotes is like an alcohol deterrent, and Revia is an antidote. Okay. So in aversion therapy, which is a type of behavior designed to make patients give up undesirable habits, so causing them to associate it with unpleasant effects. And well, it is known that it works better in theory than in reality. So one thing about this aversion therapy is there is something that they don't really want to do. They don't want to smoke, they don't want to drink, but then they realize that they do not have the willpower, self-control to avoid those things. That is where this aversion therapy comes in. So that when they see those things, there is this repulsive feeling it initiates in them. So the onset is, that's when it starts working. It takes about 2 weeks. So for instance, if you're giving a client antidotes for alcohol, you have to there are things you need to tell the client. Patient teaching. This is something that NCLEX may ask you on. Patient teaching, teach them to avoid all forms of alcohol. So even the hand disinfectants, the mouthwash, everything that has alcohol inside should be avoided. So not doing so will lead to symptoms or even death. So teach them to avoid the following items like mouthwash, cologne, perfumes, aftershave, elixir, over-the-counter medications, that's the liquid medications that may have alcohol, insect repellent, hand sanitizer, vanilla extract, so they cannot have cupcake. Okay. It's reading here that on the exam, do not pick red wine vinaigrettes. It does not have alcohol in it. NCLEX is very good at testing your knowledge and giving you what seems to be like the right answer, but then it is the wrongest wrong, if that's a word. So yes, because you see why you may just be tempted to choose that, but then it is not an alcohol. Now let's go to Overdose and withdrawal. Overdose and withdrawal, these actually came in my exam. Yeah, it came in my actual exam. So the first thing you ask yourself is this an overdose question, or is this an underdose question, or withdrawal question? Withdrawal question. So if it is an upper, is this an upper or a downer? This is because every abused drug is either an upper or a downer. However, laxative abuse in the elderly is neither upper nor downer. So for the upper, that's for the overdose, there's caffeine, cocaine, PCD, LSD, then there is methamphetamines, there is Adderall. So it is important, it is written here that memorize these five for the NCLEX. And then for the downer, now it is really easy to just know the upper. Everything that doesn't fall under the upper means it's a downer, right? So under the downer, there are over 135 drugs. So it is easy to just say caffeine, um, methamphetamines, Adderall, PCD, cocaine. Like actually, there is a way PCC, MAM. So same PCC, MAM. The P is PCD, LSD, C, cocaine. The other C, caffeine, MAM, methamphetamines, Adderall. Okay, so signs and symptoms in the upper, things go up pretty easy, right? There is everything we saw in the alkalosis: seizures, restlessness, irritability, hyperreflexia, borborygmi, tachycardia, tachypnea, diarrhea. Now, borborygmi is just increased bowel sound. That's loud singing, embarrassing bowel sound. Then for the downer, it goes down pretty easy. As it's down, then the symptom is down: lethargic, um, depression, constipation, lethargy, tiredness. So, what are the highest nursing priorities to anticipate in an upper or downer? In the upper, it means everything is high: irritability, seizure. When you think of seizure, remember suction. So, the highest priority is in an upper, anticipate suctioning. Then in a downer, then you remember that, okay, there is hypoventilation, respiratory acidosis. So there may be a need to intubate, there may be a need to give oxygen to prevent respiratory arrest. So one of your patients is high on cocaine, high is a higher, right? Upper. So it is what is critically important to assess. Having a respiratory rate of 12 is not a critical measurement to assess for that patient. However, assessing for reflexes, that's muscle reflexes, 3 plus, 4 plus, irritability, borborygmi, which means increased birth sounds, high temperature would be most appropriate. Okay. So the ABC rule does not apply here. In fact, the patient's ABC in cocaine toxicity is unremarkable. Okay. So after you know that the drug in question is either upper or downer, the second question is to ask if it is an overdose or a withdrawal, right? So in an overdose, it means the patient have had too much of cocaine, too much of caffeine, too much of methamphetamines, too much of Adderall, right? But in that overdose on an upper is too much. But overdose on a downer is too little. So this is simple. It keeps with the rule. Overdose too much of it. Overdose on a downer, too much down, like it's just too down. Then we have withdrawal. Now, withdrawal of an upper means it's too little, right? But withdrawal of a downer is too much. Very important to note the difference because sometimes it can be confusing when it comes withdrawal and overdose. There are things to look out for. So, question: the driver of a squad car calls the ER and says he's bringing a patient to the emergency department on cocaine. Remember, cocaine is an upper. What do you expect? Do you expect to see? Okay, select all that apply. Patients Patient in the ED upper. Okay, expect to see too much. The first question is it an upper or a downer? Then the second question is this an overdose or withdrawal? So the signs and symptoms, once you see the irritability, reflexes, and all that, you know that this is actually overdose. Question: the same patient is withdrawing from cocaine. Same question, but the patient is on upper in withdrawal. That's too little. Therefore, respiratory rate should be under 12 and patient is difficult to arouse. Give them Narcan. Narcan is naloxone. Narcan, this is like a trade name, but the brand name is naloxone, which is the antidote for opioids. So drug abuse in newborn, always assume intoxication, not withdrawal at birth. Okay. So in a newborn, less than 24 hours after birth, 24 hours or more after birth, you can assume that the newborn is in withdrawal. So if it is intoxication, it has to be less than 24 hours after birth. But after it has passed 24 hours, then we are talking about withdrawal. So you're caring for an infant born to a qualoed, addicted mother for 24 hours. Now we're talking about after birth, select all that apply. Overdose or withdrawal, ask the question: is this an upper or a downer? We don't know what it is because it's squalid. It's likely to be a downer because it's not cocaine, it is not caffeine, it is not meth, those things that we mentioned, the LCDs. So it's likely to be a downer. Now we ask ourselves, is this overdose or withdrawal? 24 hours after birth, remember, is withdrawal. Before, like we said, is intoxication. But this is after, then the baby is withdrawing. So, and one of the things with withdrawal symptoms in babies, they are difficult to console. They just cry endlessly. So there is seizure risk. There is this high pitched shrill cry, exaggerated startle reflex. So there is this, when you come close, there is this startle reflex. So alcohol withdrawal symptoms versus delirium tremens. Alcohol withdrawal symptoms and delirium tremens are not the same. Every alcoholic goes through alcohol withdrawal approximately 24 hours after the person stops drinking, a day after they stop drinking. However, less than 20% of alcoholics in alcohol withdrawal syndrome progresses to delirium, which is delirium tremens occurs after 72 hours. So withdrawal is after a day. But when this continues, day one, day two, that's 48 hours. And then we're counting another 24. That means that they've entered 3 days after. It means that's no longer withdrawal, but delirium tremens. Okay. So, alcohol withdrawal syndrome always precedes, it always comes before delirium tremens. However, delirium tremens does not always follow alcohol withdrawal. So, there is a table here. Alcohol withdrawal, if it is 24 hours, it's withdrawal symptom. But if it is after 72 hours of drinking, then it is delirium tremens. And the withdrawal is non-threatening to self and others. But then the tremens, the delirium, the DT, which I'd like to call it, is threatening to others. So what do you do in the next nursing care plan? Just in the withdrawal, there is regular food, semi-private room, anywhere in the unit that is calm, and then patient is up. That the patient is allowed to move around as desired, and there is no need for restraints because, of course, they are not dangerous to self or others. But when we talk about the DT, then there is nothing per mouth, nothing per oral. Clear liquid, because you want to avoid seizures. You want to keep them in a private room near nursing station so you can really look at them, observe them. Restricted bed rest, so patient is not allowed to move around as desired. No bathroom, and restraints too. So here, So what are two situations? So what two situations would respiratory arrests be a priority? Would it be, which is overdose of a downer and withdrawal of an upper? Okay. Now we go to the big guns. We are going to antibiotics, and in the antibiotics, we have aminoglycoside. Now, this is aminoglycoside is one of the top tested questions. When I was doing my NCLEX review with some books and with Uworld, I saw aminoglycoside being tested a lot. And one thing I used to remember it is the number eight, aminoglycoside, which is ototoxicity and the kidney. So you need to check the signs and symptoms for that, for the when we talk about ototoxicity, tinnitus, ringing in the ear, imbalance, but then nephrotoxicity, which is the kidney, creatinine, BUN. But the most important is creatinine. Remember our lab value of zero point 0.6 to 1.3. They need to be checked. So aminoglycoside says that they are the big guns of antibiotics. Use them when nothing else, like they're used for skin infections, bone infections. They are bactericidal. So if you want to kill the antibiotics, these are the ones to use. So the top tester questions on NCLEX, if we're not able to cover all these here on this lecture, please review. I think I'm going to do another video on these psychiatric medications. We talk about the atypical antipsychotic and all that. I'd like to do a video. So please leave in a comment if you want me to do a video or just dedicated to pharmacology. So things to remember is psychiatric medications, insulin, you must know the peak, you must know the mixing, you must know them. The anticoagulants, the digoxin, that's digitalis, and aminoglycoside. Others are the beta blockers, that's like the blood pressure, the hypertension, blood pressure medications, and obstetrics. So amine old mycin is the same as aminoglycoside and will be used to treat serious resistant, life-threatening gram-negative infections like the septic peritonitis, fulminating pyelonephritis, septic shock, infection of third-degree burn, covering over 80% of the body. However, sinusitis, otitis media, bladder infection, viral pharyngitis, trapped throat, and not old-mean infections. So they are not treated with the aminoglycosides. Now, all aminoglycoside ends in mycin. So the gentamicin, the vancomycin, the clindamycin, streptomycin, clindamycin, tropamycin. Note, not all these drugs ending in mycin are aminoglycoside, like azithromycin, thromycin. The end is mycin, but there is this throw that distinguishes them. So if you see throw, Marquez says throw them off the list, off the aminoglycoside list. So the toxic effect is mycin sounds like mice. So when you think of mice, think of ears, monitoring the hearing, that's the balance, the tinnitus, ringing in the ear, and of course the cranial nerve 8. That's what I used to remember. It's cranial nerve 8, aminoglycoside. And then the human ears are shaped like kidney beans. So another toxic effect of aminoglycoside is nephrotoxicity, toxic to the kidneys. Therefore, monitor creatinine. And it says creatinine is the best indicator of kidney function. And 24-hour creatinine clearance test is better than the serum, just the blood creatinine. Okay. What would be your answer if in a question you have to choose which is best, 24-hour or serum? Always choose the first, which is the 24 hours, okay? The figure 8 drawn inside the ear remind you of two things. They are toxic to the central nerve 8, cranial nerve, not central, cranial nerve aids, and then they are also administered every 8 hours. So in a 24-hour shift, you have to give this aminoglycoside 3 times. Do not give old mycins per oral because they are not absorbed and therefore would not have any systemic effects. There are 2 cases where the aminoglycoside can be given per oral. That's hepatic encephalopathy. That's when there is problem with the liver where ammonia level gets too high. And then there is pre-op bowel surgery to sterilize the bowel before surgery. In both cases, the antibiotic stays in the gut, not absorbed, sterilizes the bowel, and would not be toxic. So the number one action for oral mycin is sterilizing the bowel. We can sterilize the bowel the neocan. So neomycin and kanamycin are mostly used aminoglycoside in these situations. Okay. Now, very important, please, if you're not knowing anything about this, vancomycin, one thing I need to add from my notes in vancomycin is that you need to check the peak and the trough. And there is this red man syndrome associated with vancomycin. That means there is this, when given too fast, it can lead to this redness on the face, like all over, red man neck. And yes, there is something I wrote about the vancomycin that I'd like to share with you guys because this is truly, truly important. Just a minute. Yes, it says that you have to monitor the blood pressure and it is imperative that you infuse this slowly over an hour. So if it is less than 10 milligrams per that's less than 10 milligrams in a minute. To avoid some of the signs and symptoms or some of the side effects is hypotension, there is flushing and itchiness, red rash on the face, the neck, the extremities. And it is also it burns the skin, is also an irritant. So you need to assess the pain, swelling, and redness. So the trough and peaks. Trough is when the drugs is at lowest concentration. These are usually given IV, and peak is when it's on the highest concentration. So before you give vancomycin, you have to check the trough before the next concentration. Before the next administration, you need to check the trough. Okay, so tap values. A method to remember what is done before or after when dealing with a medication is the trough and the peaks. Tap, trough, administer, and then peak. Trough before you check the trough, that's the lowest concentration before administering. And then you check peak after you have administered. Trough and peak levels are drawn because of the narrow therapeutic window. I think this is like 4 to 20 of the vancomycin. Narrow therapeutic window or index means that there is a small difference in what works and what kills. So it can easily be very good, and the next moment, just a little over, it's killing the client. Which one of the following medication would trough and peak be important? We have Laxis, which is the furosemide. Furosemide is smaller dose 5 or 10 and larger dose 80 or 120. Furosemide is a diuretic, so used for CHF, the heart failures, blood pressure, relating to the blood pressure too. And then which is the second one is digitalis, that's digoxin with a smaller dose of 1.25 and larger dose of 0.25. Of course, in this case, the first thing you think of is the digitalis. So you draw tap on mean old mycin because of the narrow therapeutic index. When to draw a trough or a peak, both trough and peak are not medication dependent. The trough is always drawn, that's the lowest, is drawn 30 minutes. So not just any time, but 30 minutes before you're going to administer the next dose. And then for the peak, it depends on the route. right? So for the peak sublingual, it's 5 to 10 minutes before the drug is dissolved. IV, 15 to 30 minutes after the drug is finished or the bag is empty. So intramuscular, 30 to 60 minutes, that's like the highest concentration. The peak of the subcutaneous, that depends on the insulin. We're going to be talking about that later. And then the peak for the per oral, orally, not necessary, not tested. So it means that you have to remember the sublingual, IV, IM. So, okay? So you give 100 ml of a drug at 200 ml per hour. The drug takes about 30 minutes to run. 30 minutes to run, it means you're giving IV, right? So if you hang the drugs at 10 a.m., when will it finish running? I encourage you to take a paper, write this, calculate it, so that you know, like you have done the practice. If it comes in your exam, you can just like get this done over with. So the two right answers to pick is 11 a.m. In this case, price is right. Go with the highest time without going over. Okay. So the third question, here we come to our blood pressure medications. Very important. These questions are always there. We have the channel, the calcium channel blocker. I actually have a note on these blood pressure medications that I would like to share with you guys. I have the drug toxicity. Before we start that, I would just like to go through this drug toxicity with you guys. For I think I have four that you need to know. We have lithium. Lithium, this is used to treat manic patients, right? So the the range is 1.5. So anything 1.5 or more is toxic. The digoxin 2.0 or more is toxic. The theophylline 20 or more is toxic. Phenytoin 20 or more is toxic. So toxicity can appear as adverse effect in medication administration. And what to do, or what do you do when there is toxicity? First of all, you stop whatever is causing it. Whatever medication, if it is IV, you stop it. If it is per oral, you hold it, you don't give. Then you assess the client and immediately report to the HCP. I'm going to see that I'm still being recorded. Yes. Immediately reports to the HCP. Okay. Then in the lithium toxicity, I'd like to explain some of the things, the manifestation. The first one is excessive thirst. So there is excessive urination, there is vomiting, there is diarrhea. And it is used, like I said, to treat bipolar patients. So in this case, that it's important to, because they are losing lots of water. It is important to give them salt, encourage them to take salt, because sodium takes water, attracts water, and keeps water. It retains water. So you also give them water. And lithium is contraindicated in people that have kidney disease, cardiac disease, if they are dehydrated, because they're already losing so much and they have thirst, excessive thirst. So it is dehydrated in them. And of course, in hyponatremia, they've already lost a lot of water. And what we want to do is to give them salt. So if we see that they are hyponatremic, we don't give to them, you don't give lithium to them. So digoxin, in digoxin, one thing I remember is hazy feeling, halo around the light and all that. Everything relating to eye, when the Nclex, they may not even ask you the halo around the eyes or difficulty reading and all that. But whenever there is a problem with reading the sight, remember digoxin toxicity. So fuzzy vision, color changes, trouble reading, green halos, it's a manifestation of digoxin toxicity. So there is also dizziness. And yeah, we know that digoxin is used in the treatment of atrial fibrillation and of course to increase heart rate. Now, the antidote for this digoxin is digiband, okay, which is the digoxin immune fab. I saw this in one of my questions while I was doing the Nclex practice using Uworld. So the theophylline, it is used in the treatment of asthma, right? So everything over 30, if you check and the level is over 20, then it is bad. So the manifestation of the toxicity is restlessness, nausea and vomiting is in all the toxic effects. Digoxin, theophylline, lithium, nausea and vomiting, GI symptom is a manifestation of, well, it is manifested in nausea and vomiting. So you can always safely choose nausea and vomiting. But yeah, additional in the theophylline toxicity is restlessness, tonic clonic seizures. And of course, you educate the clients about those. Then we have the phenytoin, which is the anti-epileptic medication. They have unsteady gait, slurred speech, hand tremor. Yeah. So antidote, like I said, naloxone, Nacon is the antidote for opioid. Then we have, and one thing you should note about this naloxone is that it has a very short half life, so you may have to give it every 30 minutes. And then the benzodiazepine, we have the flumazenil, and then for the acetaminophen, that's the Tylenol, the paracetamol. Yeah, the antidote is acetylcysteine. Acetylcysteine is a medication used in the treatment of the cirrhosis, the Crohn's disease, when there is excess mucus in the GI tract that make the juice, pancreatic juice or the gastric juices not to be absorbed because they are just covered in those mucus. So all those Crohn's disease, yes. Yeah, for the antidote for magnesium sulfate, which is used in labor, is calcium gluconate. Antidote for warfarin is vitamin K. And antidote for heparin, which is also anticoagulant, is the protamine. Okay, I think these are all the antidotes and drug toxicity that I wanted to share with you from my other notes that I made here. This is the other note I made here. So that's why I was looking this way. Okay, so let's continue with the Mark K lecture note. Calcium channel blockers, they are like Valium for the heart. Valium is like relaxation for the heart, right? Like mellows the heart. I think they are like magnesium for the heart because magnesium mellows the heart, right? So in other words, calcium channel blocker, they have negative inotropic, chronotropic, and dromotropic. One thing you should know about this is that this is not nonsense good. Nclex is not asking you, it's not going to be testing you on is it negative, inotropic, chronotropic, dromotropic. No. They want to know how you apply what you know in the negative. So they may not ask you. One thing you should think about is, what do you want? When do you want to relax and slow the heart? To treat, we have 1A, 2As, and 3As. That is when we use the channel calcium channel blocker, which is CCC. So in hypertensive clients, anti anginal drugs, when there is angina pectoris, and then the anti-atrial arrhythmia. Okay, so the side effect of this medication is headache and hypotension. Very important to remember is that almost all the blood pressure medication cause hypotension, and it is imperative that you educate them that they cannot just rise up and just walk irrespective of their age. They have to stand up slowly, sit on the bed, relax, and then move, and then change the position. If not, there is a risk for fall, risk for dizziness, and fall. Okay, so the calcium channel blockers end with depine, nifedipine, and all that. Also, the verapamil or cadmium, the terrorism. So, what are the parameters to assess for the calcium channel blockers. Check the blood pressure and hold. If the systolic blood pressure is less than 100, you do not give these medications. Also, if it is less than 60, if the diastolic is less than 60, you're not giving these medications. So the cardiac arrhythmias, knowing how to interpret them, you must know the four, which is the atrial flutter, atrial fibrillation. If you've not seen, I actually recommend Mark K lecture on atrial fibrillation and all that. I'm going to link that in the description. You should check the EKGs. Those are pretty easy. And then we have the ventricular fibrillation and the ventricular problem. So yes, this is it. So we have this, the sinus rhythm is, there is a normal P wave. So there is, I can't color this, but there is a normal P wave, and then there is the QRS, right? And they fall within 5 boxes. But then the ventricular fibrillation, there is just like a tone. It's not a tone. There is no pattern actually. It's just like scattered, disorganized. One thing I used to remember fibrillation is about something like that guy is fibrillating, or that lady, she fibrillates a lot, is dishonesty, irregularity. Like today they are saying A, tomorrow they are saying B. This is what ventricular fibrillation is. There is no pattern. They're just changing as the tide comes. But in the tachycardia, tachytone, there is this constant high. There is a pattern of lies, pattern of ups. Okay? Asystole is just a flat line, usually when the patient is like going dead. Yeah. Okay, so this leads us to the next 15. Are you sure I'm going to finish? This is over an hour. If you guys were to be here, I would have asked you, should I continue? But yes, I'm going to make the decision for you guys. I'm going to continue, right? I may actually make this for 2 hours and come back. At least I should get to half of this page. And if I post this video and you guys say, oh, please continue, I would definitely come back and continue on this, okay? So we have the PVCs, the premature ventricular contractions. They are usually low priority. However, elevate them to moderate priority if under the 3 circumstances. If PVCs are 6 or more in a minute, if they are more than 6 in a row, and if they are anti-phenomenal. If there is R on T phenomenon, so a PVC falls on a T wave. PVCs after a myocardial infection is common and a low priority. Very important to remember, PVC, ordinarily, you will not even look at them twice, but then if they occur very fast in a row and they are more than 6, you're like, hey, we need to do something. It's a cause for alarm. Lethal arrhythmias are high priority and would kill a patient in 8 minutes or less. Deadly ones, and the ones that you need to act like very fast, is asystole. That's the flat line when nothing is showing. It shows the EKG shows cardiac contractility, right? Contraction of the heart muscles. If the heart is not contracting, where is the muscle? It's like the fuel to the body. If there is no energy, it just dies off, right? So both rhythms, the ventricular fibrillation and asystole, they are very high priority and we need to act fast. Both rhythms produce low or no cardiac output, without which there is inadequate or no brain perfusion, and this may lead to confusion and death, potentially. So the lethal cardiac arrhythmia is VTAC. The VTAC, that's the tomb-like one with pattern. It is potentially dangerous because it can leave it, because it has cardiac output. So how would a patient with or without cardiac output present? In the cardiac output, when cardiac output is absent, it means there is no pulse. Or when there is cardiac output, there is pulse. You can just check the in here. You can check the heart. So treatment of the PVC and the ventricular tachycardia. In the ventricular, you use lidocaine. and both are ventricular rhythm, so treats with lidocaine. Amiodarone is eventually the Nclex board we want as answer. So if you don't see lidocaine, just go for amiodarone. So we have the SVAs, right? Supra, that's ventricular arrhythmia. They are atrial arrhythmias. Treatments are, how do you treat them? We have the A, B, C, D, and S. So A, B, C, Ds. These, the S means something. Adenosine. So in this supraventricular arrhythmia, they actually go very fast. I think over 200. So adenosine, one thing you know about it is that it can lead to a feeling of death. I remember this. So you have to educate the client that there is this feeling that like the heart is stopping, but then it goes out quickly. So adenosine, fastness, but then this you give it in the supraventricular arrhythmia. You push in less than 8 seconds. So you need like super ultra fast push, 20 ml of the normal saline flush right after. And then the patient will go to asystole. That's the flat line for 30 seconds, like usually a short time, seconds, not a minute. So half of a minute. And then they will come out of it. So the beta blocker, that's the ones that end with like listen. Oh, what's the ones that end with bisoprolol? Yes, bisoprolol are the beta blockers. The calcium channel blockers can also be given, like the nifedipine, verapamil, and the digoxin can also be given. So beta blockers, here we come again. They are negative, inotropic, chronotropic, dermotropic, and they are also used just like the calcium channel blockers, antihypertensive, anti-anginal, anti-arrhythmial, anti-atrial arrhythmia. Side effects the same: headache and hypertension, like I said, in almost all the medications. So treatment of VFib, that's ventricular fibrillation, and asystole. In the fib, we have to defibrillate in ventricular fibrillation. Defib for ventricular fibrillation. And then the first thing you need to do is epinephrine, atropine. You need to give that when there is, well, you don't give, the HCP will prescribe that, but epinephrine and atropine are when there is a flat line, when there is no pulse, when there is no cardiac output, you need to give to like shock the heart, to like wake up, do something, right? Okay, so very important, chest tubes. I think I am going to end this halfway. Okay, so I will do up to 30 and then I'll come back for another video and do the rest, because here I'm also combining other part. I'm going to talk about, I guess, blood thinners. Very important. Let's talk about chest tubes. So the purpose of chest tube is to reestablish negative pressure in the pleural space. Negative pressure in the pleural space makes thin stick so that the lungs can expand when the chest wall expands. So pleural space is the space between the lung, that's the visceral pleural, and the chest wall, the parietal pleural. In a pneumothorax, chest tubes removes air. So pneumo, relating to the lungs, the chest tube, when attached, it removes air. In hemo, blood, when attached, it removes blood. But in pneumothorax, it means that the chest tube inserted, the function is to do two things: remove blood as well as air. In some of the questions, review questions, you may see a question asking you to label these forms. So it's good to know this diagram. A chest tube is placed in a patient for hemothorax. What would you, the LPN, that's licensed professional nurse, report to the nurse? Or what would you, the RN, report to the physician? The chest tube is not bubbling. Remember, we're looking for hemothorax. Bubbling is really not what we're, if it is bubbling, then we're talking about respiratory, we're talking about pneumothorax, but no, it is not. Then chest tube drains 800 mLs in the first 10 hours. That's too little. Okay. Chest tube is not draining. The intention is for it to drain. So why is it not draining? Chest tube is intermittently bubbling. Okay, that's okay. What is the chest tube supposed to do? The chest tube is supposed to drain instead of bubbling, right? So the right answer is it is not draining, because we're not talking about bubbling, we're talking about draining. So if it is not doing the function, then it's useless to be there. Now, a chest tube is placed in the patient for pneumothorax. Remember, what would you report? Chest tube is not bubbling. That's the first thing, because we're talking about the lungs. It should be bubbling. Why is it not bubbling? We don't expect it to start draining. Okay. So, also pay attention to the location the tube is placed. Apical, that's the top, and the basilar, that's the base. Apical removes air. So air and then blood, AB. So apical, top, air, blood. Of course, blood is heavier than the air. So let's just say blood, down. Okay, so an example is a chest tube is draining 300 ml the first hour. Apical, remember apical, it should be air, is draining. It shouldn't be draining, right? In the first hour is bad, because it's supposed to, the function is not to drain. So bubbling, it should be bubbling. Bubbling air is expected to show that it's working. Then a basilar chest is draining. Basilar, blood, draining. That's expected, right? Good. Then an apical chest tube is not bubbling. This is not right. It should be bubbling if it is taking out air. Apical, air, pneumothorax. It's a bad sign, because bubbling air is expected. Then the basilar chest tube is not bubbling. Well, this is a good sign, is that it's not bubbling. It means that perhaps it's draining. So patient presents with unilateral hemopneumothorax. How do you care for this patient? Place an apical chest tube for the pneumothorax and the basilar. So place an apical chest tube for the pneumothorax and a basilar for hemothorax. But bilateral pneumothorax, it means that on both sides of the lungs there is attachment of chest tube, and the functions are to remove air from both sides of the lungs. So post-trauma or post-surgical patient needs. Patient present with unilateral pneumothorax, unilateral, one side. How do you care for the patient? Now we're talking about pneumo. We're talking about pneumo. There's air. Hemo, there is blood on one side. Place an apical and basilar chest tube on that side. That's true. Always assume trauma and surgery is unilateral unless specified. Okay. True question. Where would you place a chest tube? Chest tube for a post-op right pneumonectomy. Pneumonectomy, there is excision of one, right? Of a lung. So where would you place that? Post-op, you don't need a chest tube because the lung is not there, right? So remember, ectomy is removal. Pneumo is not there, so you're not placing anything. Chest tube will, however, be placed in lobectomy. That's removal of a lobe. That's one part of the lung. But when all the part of the lungs is removed, then there is no need for it. So we have the closed chest drainage devices. Which are the Jackson Pratt, Emission, Pneumovac, and Hemovac, just the types of the chest tube drainage devices. What happens? Very important. I think I saw this question in one of my practice. Yeah. practice exercises during the Uworld practice. What happens if one of those drainages devices is knocked over? Ask the patient to take a deep breath and set the device back up. Just act fast. It is not an emergency situation, and you do not need to call the physician to pick up the device and put it back. So, if the water seal of the chest tube breaks, what do you do? Clamp. Clamping, unclamping, and placing the tube underwater must be done in 15 seconds. Now, very important, this says clamp, but the U-word and the Nclex, they would not ask you. They are not asking you to clamp because I think the mind of the Nclex is an ideal situation where the patient has continuous supply of water, of oxygen, of everything. So clamping, be very wary when you see clamping. You don't really do clamping. Okay, cut the tube away, submerge the end of the tube under sterile water. Very important, submerging so that air doesn't go in. So that it's like under the water, air doesn't go in, it's just trapped. Then you unclamp the tube if it was initially clamped. So clamping the tube prevents air to get into the chest tube but does not allow anything to go out. Note, if for whatever reason the chest tube breaks, clamp on clamping to place the tube under water must be done in less than 15 seconds or 15 seconds. That's why I'm saying that in the actual NCLEX question, when they're saying, what do you do if something breaks? If the water seal breaks, the first thing you choose is not to say, I'm clamping. No, it's submerging it in water. That's the very first priority action. Question: if the water seal of the chest tube in a patient with pneumothorax or hemothorax breaks, what is the first course of action? Now, first course of action, Marquet says clamp, but I don't think the Nclex question will tell you to clamp. But if you see the first question of clamp the tube, go ahead. But priority question is what I think they will ask you, which is submerge the tube under a sterile water. So question: the water seal chamber of a chest tube in a patient with pneumothorax, hemothorax breaks. What is the priority action? Now, the priority action, we have clamp the tube, cut the tube away, submerge the end of the tube under sterile water, unclamp. The very first thing you do is whatever answer solves the problem. In this question, the priority action is to submerge the end of the tube under sterile water, because doing so prevents air from getting into the chest. And then we have clamping, unclamping, and placing the tube must be done again. Must be done in reality, in exam situation, must be done less than 15 seconds. Like 1, 2, 3, you have to be ultra super fast. You notice on the monitor that a patient with a VFib, patient is unresponsive and there is no pulse. What is the first step in the management of this patient? Place a backboard on their patient while in supine, or start chest x-ray. The first one is to place a backboard on the patient. That's the first. Then the other question comes. Now, what they're trying to ask you is first thing, that's I have some time to do things. Okay, I can do this first. I do have some time to spare. But the best, if there is anything you're doing among all the questions, what is the first, the best, the only thing, the priority thing you can do? You're not going to say, I'm going to choose backboard first. The first priority thing to do to save that life is to start chest compression. So it is very important. NCLEX can sometimes be tricky. They will ask you first and best. It is important that you take your time, read between the lines, and read in this question. What are they asking me? Are they asking first? First, it means I have some time. In order of priority, not really in order of priority, in order of succession, what do I do first? Because I do have some time and the patient is not dying. Then you can place a backboard. But if they're telling you, if there is only one thing you can do for the client, what is that? Then you choose chest compression. Okay, so if a chest tube gets pulled out, take a gloved hand and cover the opening. That's first step. But taking a sterile Vaseline gauze, taping 3 sides is the best thing to do if you're not doing anything to save the life. The best priority thing to do. Okay, chest tube is bubbling. Ask, where is it bubbling? When is it bubbling? Ask the following question, bubbling where? In the water sealed chamber. If it is intermittent, it is good. Just document it because it's a good sign. But if it is continuous, it is bad. It indicates that there is a break or a leak in the system. Please remember these chest tube bubblings. Very important. Very easily, or these are questions you see a lot in the questions in your practice and in the actual NCLEX exam. So then we ask, bubbling, where is the bubbling? If it is in the suction control chamber, if it is intermittent, suction pressure is too low, increase it at the wall. But if it is continuous, then it's good. You just document it, okay? Water seal, intermittent is good. So analogies is straight catheter is a Foley catheter, as a thoracentesis is to chest tube. So what they're trying to say is chest tube is used to remove air or remove water, liquid from the chest tube. It's just the way straight catheter is like Foley catheter to remove urine, right? So a straight catheter goes in and out. A Foley catheter goes in, you secure it, and there is continuous drainage. Thoracentesis go in and out, but chest tube, you don't take it out immediately. You secure it, leave it in place, and let it do the work. Let it drain for some time. Okay, so rules for clamping tubes. Do not clamp for more than, if this actually comes in the NCLEX exam and they allow an option or give an option of clamping, it should never be more than 15 seconds, and it is also with a doctor's order. On your own, you cannot decide to do that. So use a rubber tooth. Use rubber tooths because they will not puncture the tubing, and double clamp. Therefore, when the water seal breaks, the nurse has more than 15 seconds to clamp, cut the tube, submerge it under sterile water. We could go to the congenital heart defect, which I think you should know. But for this point, I want to pause to talk about blood thinners. So we have the antiplatelet, we have the anticoagulants, and we have the antithrombolytics. So the antiplatelets, they are the aspirin and clopidogrel, right? Anticoagulants, we have the heparin, enoxaparin, we have the warfarin. Remember, protamine is the antidote to heparin, warfarin is vitamin K. Then we have the antithrombolytics, where they have the TPAs, that's the ones that end with ASE, like the streptokinase, the atapase, and all that. So if there is P, this is something I learned from simple nursing, the course I paid for. If there is P in the anticoagulants or in the medication that is related to blood thinning, if there is a P, then it is likely a platelet, right? So aspirin, there is P, there is a platelet, clopidogrel, a platelet, heparin is a platelet. Now, antiplatelet or blood thinners, what they do is that they lower the platelet level, so which may lead to risk for bleeding. Okay, so platelets of less than 150,000 is risky, and you could see that there is bleeding in the gums, or there is bruises on the skin. Okay, so therapeutic range for heparin, things to know. Warfarin and heparin can be started at the same time, but warfarin acts like slowly. The start is slow. Heparin is like immediately subcutaneous. They are usually given subcutaneously. They act fast. So the warfarin can be given in the pill or tablet form, But the heparin, it's usually by injection. You cannot give heparin by mouth. Okay. And you check the INR, International Rationalized Rate, for the warfarin. And for the heparin, you check the PTT, that's the proton brain timing. So the INR value is between 2 to 3, and then the PTT is 46 to 70. Antidotes, like I said, is protamine sulfate for heparin, and warfarin is vitamin K. Now, priority action in this anticoagulant administration, the first thing you do is, if you see that there is bleeding, you stop the medication, right? If it is warfarin or heparin, stop the medication. Then you assess the body, the gum, the skin, the nose for bleeding, and then immediately you notify the healthcare provider. Provide the antidotes. For heparin is protamine sulfate, for warfarin is vitamin K, and then you reassess the clients. And that's that for the anticoagulant. But one thing I wanted to add is vitamins to avoid in blood thinning therapies. And we got this memory trick, which is EGOS, the E, the GOS, EGOS. The E there is vitamin E, should be avoided when someone is taking any anticoagulant. The ginseng, the garlic, the ginkgo. Then the O stands for omega-3, fish oils, and then the S there is St. John wort. Okay, so safety considerations for bleeding risk. When there is a black tarry stool, it means that there is upper GI bleeding. But if there is a blood-tinged urine hematuria, you need to know that that's like ways to assess for bleeding. There is also this ecchymosis, so bruising under the arm, active bleeding, like peptic ulcer, and also there are some medications that are not good for people that are bleeding, like the NSAIDs, the steroids, the burana. They are not good. And then we have, in those clients that have bleeding, they should avoid those NSAIDs. And of course, people with recent surgery, because it can actually make the surgery sites to bleed more. So let's talk about let me see how many hours. Okay, this is not less than, I'm going to do this for 2 hours and we will take a break. If it is more than 2 hours, I will stop and come back. Okay. At this point, if you've not liked the video or left a comment, please do. This really helps to show this video to other people. So we're going to go to the very important congenital heart defects. It's either they cause a lot of problem or no problem. So there is nothing between. No one is sitting on the fence. So the way to memorize this is trouble, the TROUBLE, with lowercase vowels, because congenital defects are either trouble or not. Congenital means from birth, right? So a pediatric patient with trouble as congenital heart defect, it means that they will need surgery soon, or they will need surgery now or soon to live. They will have slow or delayed growth and development. This is the kind of question that may come in select order apply. And then it means that the patient may have a short life expectancy. Also, the parents may likely experience a lot of grief, financial and emotional stress, and the patient is likely to be discharged home. But then you take hospital equipment home, like the cardiac monitor. And after birth, patient may actually be in the hospital for weeks. Pediatric nurse will likely have to refer the patient to pediatric cardiologist. So the question in this congenital heart defects is, the nurse is teaching the patient of an infant with Tetralogy of Fallot. Which of the following should the nurse talk to the parent about in teaching session? Select all the apply question, like I said. The nurse should teach the newborn's parents all of the choices listed above. So the trouble, congenital heart defect, trouble, shunts, it means that there is the arrow there is shunts blood right to left, because right arrow comes before L. Okay. Trouble, there is B, cyanotic. So there is like deoxygenated blood, which is revealed, shown as cyanotic, right? Blue. Then all trouble starts with the letter T. Tetralogy of Fallot, the truncosis arteriosus, transportation of the great vessels, tricuspid atrexis, total anomalous of pulmonary vasculature. That's a mouthful, except the left ventricular hypoplastic syndrome. Now, all the T's are troubles, but there is one that you must add that is also a trouble but doesn't start with T, which is the left ventricular hypoplastic syndrome. So, if there is no T, remember, except in left ventricular hypoplastic syndrome, if there is no T, then it is normal, like the patent foraminal oval, patent ductus arteriosus, the PDA, ventricular septal defect, atrial septal defect, pulmonary stenosis. All children, I do encourage that you learn this trouble. At least when you see them, you should be able to know that these are trouble. Means that you have to teach clients, mom, that there will be dependency, shortened life expectancy, delayed growth, and all that. So, all children with congenital heart defects, whether trouble or not, will have a heart murmur, and there will also be a constant need for, or there is a need for echocardiogram. Okay. So, fourth defect of tetralogy of Fallot. Very important to know this. I think this actually came in my actual exam, which is the four things, the prove, which is the acronym. Prove that your tetralogy of Fallot. Like you come into the house or come to my house, you knock on my door, you're like, hey, I'm tetralogy of Fallot. I'm like, prove it. If you want to prove it, you should be able to say P, pulmonary arterial stenosis, RVA, which is the right ventricular hypertrophy. The O stands for overriding aorta, the V, ventricular septal defect. Now, there is no need to know how they look like, the physiology, pathophysiology, and all that, but you should be able to prove it. You should be able to spot them when you see them. Prove pulmonary arterial stenosis. I think you should actually write this down every day so it sticks to your mind. Overriding aorta, ventricular septal defect, and right ventricular hypertrophy. Okay, that's it for the congenital heart defects. Yeah, I wanted to talk about the clothes busters that I forgot to mention, which is the TPAs, the one that ends with a streptokinase, altapase. So they are given to stop blood clots, and they must be given 3 to 4.5 hours after the start of the bleeding. So more than that, they should not be given. This actually came in my NCLEX question. So the safety things you need to consider is avoid anything or anyone with active bleed. So when someone is on altapase, streptokinase, you cannot give anything by injection because there is a high risk for bleeding. And you should always check if there is a history, background of peptic ulcer, because that is going to shoot it all over the roof. Like you'll be having a bleeding GI tract, and you don't want to do that. So no new injection. You're not putting IV line. You're not giving any injection because the bleeding will be over the roof. So when I say no injection, no IV, no intramuscular, no subcutaneous, no piercing, nothing sharp on the skin. And of course, you tell them to avoid trauma, or also you check the history. If there is a recent surgery, avoid it. Okay, but now it is important that the NCLEX can be tricky. They may just ask you, okay, does this also affect menstruation? Does this make a woman to menstruate more? No. Okay, so let's continue We are now in the infectious disease and transmission based precautions. There are four transmission based precautions. We have the standard or the universal. We have the contacts, the droplet, and the airborne precaution. For the contact, there is anything enteric, that's everything GI, fecal, oral, like the C. diff, the hepatitis A, the Escherichia coli, cholera, dysentery, everything relating to GI. Staphylococcus, the RSV, respiratory syncytial. This is actually a mouthful for me. I know how to write it, but the pronunciation is a bit tricky for me. So, respiratory syncytial virus, droplets fall on the object, then patient touches object or put it in the mouth. And of course, the HEPs, these are under contact precautions that you wash your hand, put on your gloves. You don't actually have to do so much. Now, in the PPA, that's the personal protective equipment for contact precautions, is private room is preferred, but they can actually be in the same room with the same cohort. So a C. diff client can also be with another C. diff client. You wash your hands, you wear your gloves, and then you wear your gown. That's easy. You dispose of every supply you've used, and it is important for them to have dedicated equipment like the stethoscope, the blood pressure cuff, toys stay in the same room. This is for contact. But then when we go to droplets, we have the bugs traveling on large particles, and this can be transmitted by coughing, sneezing. So we have the meningitis, the influenza, and very important for the PPEs. Private room, of course, still preferred, but they can also be in the same room with the cohorts, people with the same symptom. Hand washing, mask. So in the droplet, there is need for mask. Remember, in contact, there is no need for mask, but here in the droplet, there is need for mask. So mask, there is need for goggle, face shield, gloves, disposable supply, and dedicated equipment. Then we have the airborne. One thing I used to remember is the MTV, measles, TB, that's tuberculosis, and varicella. Varicella, which is the chicken pox. MTV. Okay, so private room preferred, but of course they can be with the same people and the same cohort, patient with the same illness. Hand washing, there is a need for goggle, there is a need for face shield, gloves, gown, wear mask when leaving the room. Now, in the droplets, you don't necessarily have to wear mask when leaving the room, but here in the airborne, the MTV, measles, tuberculosis, chickenpox, wear masks when you have left the room, then you can take it out. Keep the door closed and to ensure negative airflow, dispose supply and dedicated equipment is not essential actually. Okay, so the PPP, personal protective equipment, other in reverse order. So I think there is a memory trick I used for this. That the PPP that I put on, which we call the donning, and then doffing is taken out. In the donning, we have put on the gown first, then you can put on your mask, put on the goggle and gloves. Tell me the memory trick you have. I think I'm going to leave the memory trick also in the description. But then the doffing, when you're taking it out, first of all, you take out the dirty gloves, take out the goggle before you can touch your gown. The last thing that comes out is the mask. Okay. So maths problem, dosage calculation. We have the IV, the drip rate is volume multiplied by the drip factor over time. Let's see how far I've gone. Okay. So we have, which is quite easy, but very important. I think we should go through the crutches, the canes, the walkers, and we will be done. It's not so much left in the crutches. After this, I think the next thing we will talk about will be the psychiatric medications. But let's finish with these, which is the crutches, canes, and the walkers. So one of the major human functions is locomotion. That's movement. Therefore, crutches, canes, and walkers are tested on NCLEX. I don't remember if this came in my NCLEX question, but I remember doing a lot of practice questions with this. It is important to know these. Also, such knowledge is good for patient teaching. With that being said, crutches and canes and walkers are devices used to help patients with an unstable gait whose muscles are weak or will require reduction in the load. How do you measure the length of crutches? Very important. Measuring crutches is important to reduce risk. So risk reduction when ambulating and to avoid nerve problems. So the length, very important. Crutches, the length of the crutches is measured by holding it vertically, so in a standing position, right? Vertically and placing the tip on the ground. But then there should be 2 to 3 finger wide width between the pad and the axillary fold because you don't want to place it directly over the arm. So in this case, there is 2 to 3. This picture is actually good to have. You don't place it directly. This, you can see this is bad, but here the green, 2 to 3 fingers. So it doesn't hit on the nerve and cause more problem. So rule out landmarks on feet or say axilla. Hand grip measurement, the angle of elbow flexion is 30 degrees. You can see 30 degrees, and the wrist should be at the same level with the hand grip. How to teach crutch gait, 2 point gait. Move a crutch and then the opposite foot. This diagram shows this is the tripod, this is them standing here. So you move the leg, it's like you taking turns, move a crutch and then the opposite foot. Move the other foot and then the opposite leg. Okay, so together you have right leg, left crutch, left leg, right crutch. Then the 3 point. Now this is used for mild, not like major, but mild bilateral leg weakness. But in the 3 points gait, it's like 2 crutches moving and then the bad leg. First of all, put the crutches, then the bad leg follows. So it's like 3 to 1, right? So the affected or bad leg is not on the ground yet. Then the affected or good leg is on the ground. 4 points gait is move everything separately. So you move opposite feet. This is like really slow. Move opposite feet and then you move the other crutch. Then you move the opposite feet and you move the other crutch. So right crutch, left foot, left crutch, the right foot. Very, very slow. But one thing about this is that although it's very slow, it is very stable. So the diagram here shows it. Again, I'm going to link this so that you can follow along as I am teaching. Then the swing through is similar to the 3 points, but in this one, the unaffected leg gets past the tip of the both crutches. So the person may be an amputee, like one knee is chopped off and does not bear weight on the leg at all. And in this case, they can actually move fast. So when do you use these gaits? For even gaits, for even point gaits, for even, and odd point gait for odd, right? So the even numbered gaits, when the weakness is evenly distributed for the mild problems. And then for the 4 point gait is when it's severe. For the odd point, when the one leg is affected, you use 3 points. But for the swing through, when they can no longer bear any weight, then they have to swing through. Okay, a patient affected with early stage, meaning it's mild, right? What points of rheumatoid arthritis, what gaits should the patient use? both legs are affected. Remember, because it is systematic. Sorry, not systematic, but systemic. So early stage is mild. That's the 2-point gait. Example. So there is a patient has left above the knee amputation. Above the knee on the left side is amputated. So there is no leg beyond the knee. What do? There is no weight bearing, so you have to swing through. In this case, you don't use three gates. But then there is first day post-op. Like the right knee is there is partial weight bearing allowed. What gate should they use? Then we have the 3-point gate. One leg is affected, it's like odd numbered. But then patient is in an advanced stage of ALS. What gate should they use? There is bilateral leg weakness because it is systemic. So even gate, advanced stage, severe, there is a need for 4-stage. Very slow but very stable. So patients with left heel replacement, second day post-op on non-weight bearing instruction. They are not bearing any weight. When there is no weight bearing, then they just swing through, right? So patients with bilateral, both leg replacement, but weight, and it's first day post-op, but weight bearing is allowed. What can they use? The 4th gate. The 4th-point gate, because they can go slowly but stable, because it is even number, right? There is weight bearing, and then it's post-op. It's still severe. So we also have going up and down the stairs. Up with the good, down with the bad. You want to have the first impression. You want to do the first thing first. So remember this phrase, going up the stairs. Up with the good, down with the bad. If you're going up, you put the good leg first, then other ones come. But if you're going down, down goes first before the crutches come. So when you go up the stairs, move the good foot first so that it will bear the weight. Then when you're going down, the bad foot should go down first while the good foot is still on the ground. But no matter what, both crutches always move with the bad leg. So here's a picture of it. This is person coming down, down with the bad, down with the bad. Cane should always be on the good side. Have the cane when you're holding the cane. Okay, so cane, hold cane on the unaffected, that strong side. Advance the cane with the opposite side for the wide base support. Hand grip should always be at the wrist level. And then for the walker, correct way to use the walker, the picture is here. I think this came in one of my exams. The walker is on the side of the patient. He picks it up, sets it down, walks to it. Once the walker is in front of the patient, he holds onto the chair. Now, he doesn't hold onto the walker, but the chair he's sitting on stands up. It is only after he's up, standing, that he grabs the walker. Very important to check this. That although the walker is in front, he doesn't get it immediately. He holds onto the chair first. So it is important not to tie belongings to the front of the walker. It's better to tie them on the side so they don't tip over. Now, Nclex board does not like tennis balls or wheels on walker because they can create problem. So I think I'm going to end here because I don't want this video to go more than this, really. I will come back and do another video starting from the psychiatry, and we will do more. I think it's better we do it that way. We will do more of this, but it's better that we end with this cane for now, and let's come back and do more. This is like an impromptu video, and I hope that you find this really helpful. I just had this impression to share with you guys, and this content is not mine, so it is from someone that shared this note, but it really helped me. These are the content I used to really refresh, and then I started practicing with the Uworld, and it was really a game changer. I encourage you to write. I encourage you to leave your comments. Please leave your comments. To really help me a lot. It's like you telling me thank you for the time. My kids are sleeping. I should be sleeping. It's way past my bedtime, but I'm like, let me do it for you. So please help me. Click on the like button. Share this to your WhatsApp group. Anyone that is your reading partner, share it on a Facebook group. Like, please like this video. One way to really encourage me to do more of this is to share it so that others can benefit from it. Send the link to somebody, mention me to somebody. And if you're writing your NCLEX soon, or you want help, or you just need some kind of coaching if you're back home in Africa and you're thinking of how to navigate moving to the US and all that, I have made an ebook that I'm going to link in the description. So thank you so much for being here, and I'm going to see you all in my next video. Bye.